from the breastbone to the pubic bone, and then just to find out if you have disease or not. So there is a lot of things that we don't know how to approach. Things change. And like I said, I think that the PMP patient from 2011 is very different than the PMP patient from the 1990s. This is another patient, also with PMP, who had a right colectomy and then developed a leak. And they put a catheter to drain the leak. And then this, right where the catheter was coming out, this is a 2 centimeters, so less than 1 inch. It's just a really big picture. So, I also show this slide because for any one of you that knows about base jumping, you know, base stands for buildings, antennas, skyscrapers, and environmental tall things. I don't know the E part. But so this is a picture of this fellow here jumping in Mexico. This is a 3,000 feet deep jump. And they asked the guy, you know, he's the first base jumper of the Cañón del Sumidero. They asked him, what words of advice do you have for people that are going to start doing this jumping, you know? And he said, well, we have 2 buckets, one full of luck and one empty of experience. We need to fill up the latter without emptying the former. So I changed that slide and I said the current HIPEC situation in the United States. I think we have 2 buckets, one full of enthusiasm and one empty of data. We need to fill up the latter without emptying the former. And I'm just going to talk a little bit about the problems with randomized trials. This is another publication in the British Medical Journal. You know, I didn't make this up. You know, here's the reference. Parachute used to prevent death and major trauma related to gravitational challenge. Systematic review of randomized controlled trials. So this is the conclusion of the study. Parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized controlled trials. Dr. Sugar-Baker, you may wish to add this to the list of things that do not need a randomized trial to be proven. And I also modified, that's what kind of what I do, you know. I find something, I like it, and then I modify it a little bit. And so what I did with this is what's happening, you know. Here's the PSM, the peritoneal surface malignancy plane, and people are jumping with FOLFIRI, CPT-11 plus Erbitux, Folfox, and Avastin, HIPEC. Everybody thinks they know they have the parachute and that it does not need to be studied. So it's a real problem. If this is not for PMP, but this represents exactly the problem with colon cancer. As Dr. Ryan said on that debate that Dr. Sugar-Baker was talking about, I think there are people on both sides, you know, HIPEC and no HIPEC believers, who they know what's best. Some of us saying absolutely cytoreduction and HIPEC is the way to go, and then some medical oncologists that said absolutely not, you know. So it is a problem. Having said that, what about a review of the prospective randomized studies evaluating HIPEC versus not HIPEC in addition to surgery? Just earlier this month, I think this is the first study, as I'm aware, and please correct me if I'm wrong or if somebody knows of any other study, in which they took patients to the operating room with gastric cancer. This is in Japan, and like I said, just published this month. And they had surgery, and then at that time they were randomized. Half would get HIPEC, and half would not get HIPEC. And that is the purest way to evaluate how much HIPEC adds to an operation. Well, the numbers are small, which means that you need a really big difference. You know, when you have 1,000 patients in one arm and 2,000 in the other, well, you know, even a tiny little bit difference will have a statistical significance. We know that in the treatment of pancreatic cancer, in which Tarceva had an improvement of survival of 14 days. So the patients that received this drug for advanced pancreatic cancer lived 14 days longer, but since they had a lot of patients, it was statistically significant and got the stamp from the FDA. Now here, just with 34 patients in each arm, it was a statistically significant study. And I think that right now is the only study that I can say that has shown that HIPEC is beneficial after surgery. There are 2 other studies that are in progress. As you can see, none in the United States. The Dutch, in patients with ovarian cancer, HIPEC versus non-HIPEC after cytoreduction. And then the French group is comparing the same thing, but in patients with colorectal cancer. Let me see where. Let me just go back a little bit. In terms of our study, since I do have a few more minutes. In terms of our study, which is a prospective randomized trial to compare best systemic therapy versus cytoreduction with heated chemo in patients with colorectal cancer, it's been open for 10 months. It's been started only in 3 centers out of 15 that were supposed to enroll patients, and 1 patient has been enrolled. So now the government, the National Cancer Institute, is asking us to modify our protocol and to allow patients that have received chemotherapy to enter to the protocol. And that I don't know how someone who failed FOLFOX and Avastin can be randomized to receive more chemo or surgery. So I don't think that's going to work. So the other trial for the mandatory second loop surgery in colorectal cancer at the National Cancer Institute has been open for 18 months, and they have not accrued 1 single patient. So I think that the problem of collaboration and doing prospective randomized trials in the United States is just not something that's going to happen. But we do need data. There is no question that we need data. You know, I wrote here, with a word of caution, you know, it is funny how research data can change today's truth into tomorrow's inaccuracies. Breast cancer and ultra-radical mastectomy. You know, we were here in the 50s, we were talking about, you know, we're going to take 3 ribs, a muscle, and end up with a huge arm. And now the role of surgery in breast cancer is very, very limited. Anal cancer and abdominal peritoneal resection. For anal cancer, you used to just take it out, and now, you know, just get chemo and radiation. And even for rectal cancer, we used to say, well, if you can feel the tumor, that means you need to have a removal of your sphincter and have a permanent bag. And now, I think that in GI malignancies, rectal cancer is the paradigm of a multidisciplinary treatment because it involves surgery, chemotherapy, and radiation. So, final conclusions. I am pro-HIPEC in pseudomyxoma because, like I said, you know, there's no question that the best outcome reported data comes from this combination. I think that we need to establish a peritoneal surface disease severity score for PMP in order to individualize the treatment, the comparison of treatments. I mean, I don't know of any, like I said, we cannot possibly believe that if HIPEC works, it's going to work on everybody. So we need to find out those who do not need HIPEC, and we need to find out those in which HIPEC is not going to make a difference. So we can talk about expected morbidity and mortality and expected outcomes. I think that we need guidelines, and we need to standardize the HIPEC. We can't have 14 different ways of giving HIPEC. That's part of the problem. You know, the medical oncologists say, well, you give this drug, this much amount per body surface area, and they do it the same everywhere. So those are part of the problems. I think we need to work as a team between patients, medical and surgical oncologists. We need to get together and request from the American Cancer Society and the National Comprehensive Cancer Network to include appendix cancer in their diagnosis and guidelines. If you call the American Cancer Society and say, listen, I have PMP, what should I do? There is nothing out there. If you go to the guidelines, which are like, you know, the standard of care for the management of all the malignancies, there is nothing. And I checked them just before coming, just because, you know, somebody put something there that I didn't know. And I think as a group like this one, we can get it done. I think that part of the research maybe would be to, you know, sponsor a panel of expert meeting, you know, which will have medical and surgical oncologists, people that believe and people that don't believe, and then at least say, okay, these are the guidelines, and then approach these institutes and say, well, listen, we got together and we came up with this, you know, and the level of evidence is going to be low, but most of those guidelines, that's what they are. They're not, the vast majority of the guidelines published to dictate the management of cancer patients is not level 1 evidence. I included, these are the other 2 slides that I had. Dr. Barnes, he was the president of Memorial Sloan Kettering, and then Obama took him to the National Cancer Institute as the director. And he just said, 3 days ago, the days of one-size-fits-all cancer therapies are disappearing, and we are entering a new era of tailor-made medicines that will be more effective and have fewer side effects. That is the statement of the president of the National Cancer Institute 3 days ago. I think that this is a reality. I wrote here MSK because 12 days from today, Wednesday, June 29th, Memorial Sloan Kettering was going to have their first HIPEC procedure. I interviewed for that position in 2004. Ever since then, they've been trying and trying. They asked me to proctor the case. I had to amend my contract with Agnes, got all the lawyers, everything involved, and just yesterday, I received a note from Memorial Sloan Kettering, the case has been canceled. The medical oncologists will not allow a HIPEC to take place at Sloan Kettering. So, whether we like it or not, that's a reality. We don't make the rules of the game, but we have to look at them, and we have to figure out how to work as a group to try to do that. I was so excited. I said, the impact of Memorial having the first HIPEC case is going to have a tremendous benefit. That's what I wrote, on the emails to them. I said, this will have a tremendous impact and benefit for all patients with peritoneal surface malignancies outside of Sloan Kettering. Because that's, you say, oh, well, if they do it, then it must be good. And now it's just the opposite, It's I don't know how, but this information leaked, and I got a phone call from a reporter from the New York Times who wanted to interview me before the procedure and wanted to get a little bit more information, and I'm so happy that I said, no, you got to talk to them. I cannot tell you anything. And now that the case is canceled, so probably it's going to be even, I'm sure he'll proceed with the report in the New York Times, and he's going to set us back in another couple of years. Ooh, sorry, I went over 1 minute. Thank you very much for your attention.
A couple of really quick housekeeping things that I have been asked to address to help yourself to those if you're feeling cold. And then the third thing is that we're actually making a slight program change where at 11 o'clock we're going to do the case presentations and discussions in here using some of the equipment and the screen, and then move the expert panel and Q&A session to over lunch, which probably works out just as well anyway. But again, if you have questions, if you want to use the note cards and hand them to me or someone else who looks like they know what to do with them, we can try to organize the question and answer period a little bit. But now we'll move on to Dr. Laura Lambert. Dr. Lambert is from UMass Memorial Medical Center and is the director of their peritoneal surface malignancy program. Dr. Lambert spends the majority of her time in her practice and research dedicated to peritoneal surface malignancies, and established the clinical and translational research program at UMass. She's dedicated to education of clinicians regarding diagnosis and treatment options of these diseases. She's also a very active researcher. Dr. Lambert, we all know from relatively personal experiences, also advocates very hard for patients and their families and spends time with them trying to help increase awareness and an understanding of PMP and related diseases. And Dr. Lambert also has volunteered her time and serves on our professional advisory board for the PMP Research Foundation. So we appreciate the time that she gives us there. Without any more, Dr. Lambert.
Thank you. Good morning. Can everybody hear me? Yeah. I'm not as tall as Dr. Sugarvick or Dr. Esquivel or Dr. Sardi, so it's hard to see me sometimes behind the computer here. But first of all, I just want to thank all the people who are dealing with PMP and their families who are here to support them, for the privilege to be able to talk to you again today. And I want to thank Jerry and Jim and all the people with the PMP Research Foundation for letting me help them with their efforts as well with this incredible problem that we're facing. And just I want to also make just say that this is truly a privilege to share the podium with Dr. Sugarvick, Dr. Esquivel, and Dr. Sardi. A real sign of, well, just to be recognized with these gentlemen, it's beyond words at this point. So without any further ado, I'm going to change the topic a little bit today and talk to you about what are some options for advanced pseudomyxoma and appendiceal cancer. And we had a symposium up at UMass a couple of weeks ago, and I showed this slide because this is sort of what I experience with people when they come to my clinic for the first time and they've gotten this diagnosis of pseudomyxoma or mucinous neoplasm of the appendix or appendiceal cancer. And like Dr. Esquivel said, you call the American Cancer Society and they say, well, we don't know what to tell you. We don't know how to treat this. And you go online and you start reading some of the most scary things you can possibly read. And it's really confusing, right? It's you've got this disease with this name that's incredibly hard to pronounce. Sometimes it's cancer, sometimes it's not. But even if it's not cancer, it can be a life-threatening illness. And then you start looking at what are the treatments for it, right? Oh my goodness, they want to do this crazy surgery, put heated chemotherapy in the belly. And how does anybody possibly survive this? Does it have any benefit? And then you hear about debates at the American Society of Clinical Oncology, right? The biggest cancer meeting of the year. And you have a medical oncologist from a prestigious institution in Boston saying that there's no role for this. And so you've heard about some of the controversies that we're dealing with and the struggle that we're having. But to be the individual going through this and dealing with this really is the perfect storm. So like I said, it's a rare tumor or cancer, right? So your patients' families are asking them, well, do you have cancer? And the person doesn't know how to answer that question. Some people say it is, some people say it isn't. Unfortunately, although, as Dr. Esquivel pointed out, we are starting to see fewer and fewer people getting to us at very advanced stages, like some of the CT scans he shows, which I hope is a sign of the improvement that we're making in awareness among general surgeons who encounter this at the time of surgery for an appendectomy. They think somebody has appendicitis and they find this instead. Or the gynecologists who go in thinking they're dealing with ovarian cancer and they find something else. And that the professionals are starting to recognize this as an entity, a problem, and getting people to the appropriate centers for treatment where they can be treated for this comprehensively. And as I mentioned, one of the best available treatments is really one of the most daunting therapies offered in medicine. A major surgery combined with heated chemotherapy at the same time, and sometimes chemotherapy after the surgery as well, in the setting sometimes of having just received a lot of chemotherapy. So it is really daunting, and unfortunately, we still see a lot of people who aren't candidates for this therapy. You've heard some of the rules and regulations about when the cytoreduction or the chemosurgery can be beneficial. And one of the leading indications or requirements is that the surgeon at the time of evaluating the patient feels that he or she can remove all the tumor at the time of surgery, because really it's only then if you can get it down to that very small amount of tumor nodules that are left behind, if you have to leave any behind, that the heated chemotherapy is going to have a benefit in terms of survival from the cancer. So a lot of times when I see people, this is how they feel. They're kind of like Alice falling down the rabbit hole, and they're grabbing for any information, not just information about what to do next, but prognosis. And if any of you have asked a doctor about prognosis, right, we just sort of that's what we just sort of back out. You know, we're all sitting forward, and then when it gets to the prognosis part, because a lot of times we don't know. And we can give people statistics, we can tell them the average, as best best I can tell, based on the information that I have about you, if I look through the literature, you would fit in this category here, and this would be the average. But how many times have we told somebody this is where you'd be and they've proven us wrong? And so we really, people need that information. They need to have some sense of what is the prognosis. But as physicians, we really hate to tell people because we don't know. We don't know. What we do know is that we're going to try to figure out what the best thing to do is, get you on that plan, support you through that plan the whole way, and try to get, obviously everybody is, when they come, they're looking for the cure. Right? They want to know, can this be cured? Can I be cured? Because what is it going to take to do that? And unfortunately, a lot of times with this particular problem, by the nature of the way it spreads and the amount of treatment that is required for it, cure is really sometimes not an option. But there are other things that we can do, things that we can do to help give people survival, to help them to live longer. But in addition to that, we want to make sure that they're living well with the time that they have. So how do we decide what, for patients who come with really advanced pseudomyxoma or advanced appendiceal cancer, for whom, unfortunately, cytoreductive surgery and heated intraperitoneal chemotherapy is probably not the right option? Well, there's a number of things that we have to take into consideration when we're thinking about what those options might be. Obviously, the clinical situation. Somebody may be coming to us having already had a number of surgeries, having had a lot of chemotherapy. This is actually a time when when the medical oncologists who are now up against the wall and they have nothing else to offer, now they think about cytoreductive surgery and heated intraperitoneal chemotherapy. And I know all the surgical oncologists in here who deal with this, this is a huge frustration for us because we look back and we say, wow, if we had gotten involved at the beginning, we probably could have used surgery and the heated intraperitoneal chemotherapy. Now, unfortunately, it is too late for that. So there's not only the previous treatments, but also the physical condition of the person. We are talking, if you've been online, you know that these surgeries can sometimes take 12, 15 hours to do. Again, the combination of major surgery that it requires the stamina to go through, then followed up with heated intraperitoneal chemotherapy, which has its side effects. So a person really needs to be in some physical shape to go through the surgery. And then the emotional condition of the person. This is hugely important as you're trying to decide what is the next best thing to do. And this is not something that we as surgeons necessarily focus on, right? Somebody's coming to see a surgeon, the question is surgery or no surgery, and a lot of times that's the answer that you'll get. But to do a truly comprehensive, multidisciplinary thinking of all aspects of what is a person dealing with, this component really needs to be taken into account as you're trying to decide what the next best step is. And then, of course, there's the tumor biology. So we've talked about how these tumors of the appendix present as a spectrum, right? From a tumor, and I use that word specifically, not a cancer, but a tumor that can go on to cause pseudomyxoma. And a lot of times you'll see something called a mucinous cyst adenoma or a mucinous neoplasm of uncertain malignant potential. That's another way the pathologists like to refer to it. Those are tumors that are not technically cancers. I'm not going to get into the biology of that. But that biology, that description by the pathologist and how those cells look under the microscope give us a clue as to how these tumors might or might not respond to the intravenous chemotherapy if that's one of the options that's available. So that's important for us to know. On the other end of the spectrum, everybody's heard about the signet ring cell and the poorly differentiated adenocarcinomas. Now, there's actually data to show that you can get a response in those tumors by giving intravenous chemotherapy, and we're fortunate in this era to have chemotherapies that actually work, that have improved the survival of patients with colorectal cancer, and these signet ring cells and poorly differentiated adenocarcinomas of the appendix are very close cousins to true colon cancers. And so the intravenous chemotherapy that we use for colon cancer that can be given by really any medical oncologist, their standard of care treatments, can have an impact on patients with the poorly differentiated signet ring cell appendiceal cancers. And then again, the extent of the disease. So there are certain criteria as a surgeon when you come, we look at the CAT scans, we look at the MRI to see if, from a surgical standpoint, is there anything we can do? Can we get a complete tumor removal? Or is there a bowel blockage that's causing symptoms? Can we remove that safely with surgery? And then there's logistics. So as Dr. Sugarbaker said, I didn't realize that there are 120 centers now that are offering heated intraperitoneal chemotherapy, but I think anybody who is really facing this challenge and thinking about this surgery, you're looking for the centers that have an established program, a program that it's not just the surgeon. This is not just about the surgeon, right? This is about what's going to happen afterwards. Is there somebody else in the clinic who knows about this? If I make a phone call, is somebody going to be able to answer my questions? Have the anesthesiologist given anesthesia for this problem before? Do the nurses on the floor know what to look for? Have they ever seen this before? It is a team, it requires a team to do this well, and an institutional commitment, the resources, the personnel, and the understanding of the disease. So a lot of people will have to travel quite a distance to get that, because that's important. There are family concerns. If you're going to be away from your family, if you have young children, these things all weigh into decisions about what you can and should do. And obviously, unfortunately, we still hear so much about financial concerns. Whether or not the insurance company is going to cover this, how can I pay for this, and that sort of thing. So one of the things, if we're in a situation where unfortunately sometimes we are, that really cure is not a reasonable option, we always hold out the hope that something new is going to come down the pike, that we're going to find something that's really going to have an impact, or that something literally almost miraculous in our expectations can happen as we start down the path to treatment. But we may not be actually focusing on getting a cure, but rather just sort of controlling the disease. Controlling the disease, hopefully preventing it from growing and maintaining the current status, or to decrease the rate of growth, or to prevent it from spreading to other parts of the body. And some of the things that we use, I just would call as standard therapy, usually involve intravenous types of chemotherapy. Again, we go back to that histology. What does the cells look like under the microscope? Do we think intravenous chemotherapy could be a benefit? And sometimes in rare situations we use radiation, again, very specific to certain circumstances within an individual patient. And then the other option at this point in time can be to consider something experimental, getting involved in a research study where we're not necessarily, perhaps we really don't have any more options that we think, that we know, that we have established, that we have a reasonable expectation to think that they're going to control the disease. And this point in time might be reasonable to consider a research study to test new treatments that look at the safety or efficacy of a type of new treatment, and it may not necessarily provide an advantage in terms of survival, but it may be something that it might. And so if somebody is well enough and interested in joining or being involved in a clinical study, we welcome that. We thank people for doing that. We're grateful for that. It helps people in the future. It may not benefit the actual person going through the study. And then there are also clinical trials that are designed to determine survival benefit. And I'm not going to list any here, but there are certainly clinical trials available, some specifically for PMP and appendiceal cancer, but others that are, if you were to be looking, searching, if you wanted to go online and search, if you search under carcinomatosis, that's where you can find the clinical trials that are available specifically for carcinomatosis, and those would include PMP and appendiceal cancer. Now, the other options for advanced PMP and appendiceal cancer, and for any advanced type of cancer, is there's something called palliative care. And so I'm just going to poll the audience. Who has heard of palliative care? Okay, great. I want a little bit of audience participation here. I want it from people who have not had any interaction with palliative care. You've heard about palliative care, but you've not actually had anybody that you know receive palliative care or be involved in palliative care. What sorts of thoughts come to your mind when you hear about palliative care? Anybody? Comfort?
Yeah.
Comfort? What else?
Maybe possible extension of treatment to help give you an extension in your lifestyle.
Okay.
It's not a cure, but trying to maintain the best quality of life or whatever.
Right, that's maintaining the best quality of life, right. What else? Anybody else?
Pain management.
Pain management, yep. Anything else? These are all really positive. I am wonderfully surprised by this response.
As a nurse that
Yeah.
deals with these, I
Yeah.
think the first thing that